diseases. Now we move on to another important infectious uveitis, which is predominant in our country, tubercular posterior uveitis, and to deal with no other than Dr. Vishali Gupta, Professor Vishali Gupta from PGI Chandigarh, who had done seminal work on tubercular posterior uveitis, including the collaborative ocular tuberculosis study. And Dr. Vishali Gupta will be talking on tubercular posterior uveitis, new strategy of diagnosis and treatment. Professor Vishali, please.
Thank you, Dr. Biswas. So, sir gave me a topic of new strategy of diagnosis and treatment. I don't think we have a new strategy. So, let's talk about what are the challenges which you face. As a comprehensive ophthalmologist, it's important to know how to diagnose. But when you diagnose, you believe that it's the end of the challenge, but in fact, it's the beginning of a whole set of new challenges because you are confused when to start therapy. Give it a local or systemic. Should you give steroids? Should you not? And what should be the timing of starting steroids, stopping steroids? So let's go over it one by one. And the question which is most commonly asked is that do you need a internist or a pulmonologist to start treatment? And if you, God forbid, ask them to start treatment, they generally tell you there is no evidence of TB in the body and we will not give treatment. So that is something which very commonly we encounter. So what is the customary uveitis management is, when we deliver it, it may not have lot of variations because we all are trained differently, we all have different practices, we all have different logistics, and TB, I think, tops the list where all these practices and all come into matter. So, how do we learn the new strategies that Dr. Biswas told me that what are the new strategies? The problem is we all rely on our training, and our training beliefs in uveitis and especially in tuberculosis may be different from one big institute to another. When we go to practice, we go on with whatever knowledge we have acquired, and that's a default emotion. And then we need here a multidisciplinary approach. And sometimes internists always, make to feel you that they are superior to ophthalmologists and they know better than you, and they generally kind of tell you that, well, patient does not need TB treatment. So that is the purpose. I'm just going to tell very briefly what has changed. I'm not going to go over the literature and all. I'm just going to give you the pearls that we have got from our collaborative tuberculosis study group. The most important thing we realized was TB has various manifestations in different part of the world. So if you have a patient coming from another continent or another country, the manifestations may be different. Manifestations would also vary from different state to state. A simple example, Singapore and China does not see much of serpiginous like choroiditis, whereas the Indian continent and the European are very high on serpiginous choroiditis as manifestation of TB. So the clinical presentation could vary from the country of origin. The second thing is, which we realized on various permutations and combinations, is that the basic investigation so far still remain chest imaging, and CT scan is much better than X-ray. X-ray generally does not pick up, CT does. Monteus is still the gold standard, especially in a country like ours where it is available. And quantiferon TB Gold, even though it is banned by the government of India for making the diagnosis of pulmonary TB, is still very useful when we are looking at ocular TB. So these are the three investigations that majority of the experts still rely on. PCR is available only in few institutes and it is mostly in-house PCR because the a closed loop system, Gene Expert does not really show you very high sensitivity. So don't be concerned that you have to rely on PCR to make the diagnosis. You can be done with very simple basic methods. That is what is new in diagnosis, if you ask me. It's basically what is old, but the same things which were. And maybe Soumya Basu is sitting at the back, so he has this idea that we should have diagnosis based on the clinical features alone. We have not reached there yet, but we may in future. But for the time being, it is the clinical phenotype suggestive of TB. Positive PPD skin test are Monteus, quantiferon TB gold if you can do. If you can't, even then it's okay. And the chest CT. Important point to remember is that when you are doing chest CT, you are not looking for active pulmonary TB. CORDS data showed that 89% of the patients do not have active disease anywhere in the body. And out of the remaining 11%, those who have, majority may be in the cervical or lymph nodes and not in the lungs. So when we are looking at the CT, it is just to look at some calcified lymph nodes, Gons focus. We are really not looking at active lesions. Now comes treatment. When do you treat? So the treatment would depend on what is your phenotype. For example, in India, it's the serpiginous like choroiditis, which is one of the most specific presentations of TB. So you would start anti-TB if if all three, PPD, IGRA, and chest imaging is positive. If PPD, IGRA are positive, or even if one of the tests is positive, you will start this patient on anti-TB therapy. Important point to remember is when we start them on therapy, there is going to be paradoxical worsening, which occurs almost in 40% of the patients. And as you see here, this is before you start treatment, and notice these lesions. Once the treatment is started, the paradoxical worsening is characterized by increase in the previous lesions and the development of the new lesions. So now there is paradoxical worsening and the patient is already on ATT and steroids. What would you do? This worsening is due to increase in the cytokines which appear when the ATT starts working, typically comes in about 2 to 3 weeks time, and this can be managed by giving local steroids, local methotrexate, or increasing systemic steroids. So would you use steroids concomitant? Yes. There is a role of concomitant steroids in the phenotype serpiginous like choroiditis to prevent paradoxical worsening because it has a high incidence. Patient may not always complain because many a times this worsening happens in the periphery. So in patients where you are not able to take them off corticosteroids, or the disease is progressing despite ATT and you do realize that they are dependent on steroids, steroid sparers can be given. For the other things also, anterior uveitis, we do not recommend starting treatment in the first go, but if you have the recurrences and two test positive, it may be started. Intermediate uveitis is difficult to treat, and many a times Monteus may be incidentally positive and difficult to manage with ATT alone. So the treatment is only when all the three tests are positive. So this is just a very simple. It is available on IUSG website for those of you who want to download. You just enter patient's name, age, gender, country, and whichever eye, and very simple phenotype, like is it choroiditis, whatever it is, it will automatically tell you once you enter the country. And these are the only three tests it is asking for: Monteus, IGRA, and chest imaging. It says X-ray, but it is about chest imaging. And then it gives you the result. The result will come like very high probability amongst expert, which means 90% of the experts would consider giving ATT to this patient. So, this is a tool which can be very useful for comprehensive ophthalmologists who are trying to figure out to give ATT or not. And with this, I would like to thank Dr. Biswas for the very kind